I'm a board certified psychiatrist, and I've helped over 160 PMHNPs get confident in psychiatric diagnosis, treatment, and treating their own clinical cases with confidence and clarity. If you've ever been confused about how to use Seroquel, how to titrate it, what to use it on, how it works, and how to use it effectively with patients, keep watching this video. So Seroquel, the most important thing that we got to know about it, even starting out, is that how it works. It's different than the other antipsychotics. So the MOA, mechanism of action. So it's got dopamine blockade, just like all the others do. So it's got that D2 blockade. But the thing about it is that the D2 antagonism is very light. So, all right, not potent. And because it's not potent, the advantage is that you can use higher doses of it. So it's like, for example, risperidone is like 1 to 8 milligrams, or Zyprexa is 1 to 20 milligrams. This, the dose goes a lot higher, like 1 to 600, and we'll get into that. So it's got the D2 antagonism, so D2 ant, but it's got some other things as well, and that's what makes Seroquel one of my favorite antipsychotics to prescribe. So other than that, it also has 5-HT1A antagonism. The reason this is important is because when you have this 5-HT antagonism, this gives it mood benefits. So that's why for Seroquel, we use it for bipolar disorder, we use it for treatment-resistant depression, we use it for depression augmentation. That's the advantage that the 5-HT21A antagonism gives. And so we have that, but we also have histamine antagonism. And so when you have histamine antagonism, this is super important because this causes the sedation and weight gain. So now with Seroquel, if we have the sedation, we have the weight gain, this makes Seroquel very, that's why it has that effect on people. So weight gain is a big problem with this medication. Another one is the alpha-1 antagonism. As this decreases blood pressure. So sometimes Seroquel can lower people's blood pressure and can make them dizzy, can make them lightheaded. So that's where that comes from. So the main uses that Seroquel has are for schizophrenia, bipolar, both manic and depressed. Seroquel is used for both the mania side and the depressive side. So that's super helpful because let's say a patient comes in inpatient. I like using Seroquel a lot for bipolar patients because you'll be able to help the mania, you'll be able to help them go to sleep, and maintain them on it for the depressive side of bipolar. So that's why I like it. It's also used for insomnia at low doses. You wouldn't use this for high doses, but low doses you definitely can use. I've also really liked Seroquel in 2 off-label uses as well. So I've liked it for BPD, and I like Seroquel for BPD because of the mood lability. So decrease mood lability. Because when I'm treating BPD, I want to use lower doses. I don't necessarily want to use higher level antipsychotic doses, but I want to use more mood stabilizing doses. That's why I like it for BPD. I used it a lot for PTSD, for both the sleep and mood ability. So I used it a lot in my VA patients because I would use it as augmentation. So let's say I had an SSRI on treating PTSD, then I would add on Seroquel as well as an adjunct, and then I could titrate that based on the patient's response. So talking about the dosing of it, and this is the unique part about Seroquel. I'll divide it into 3 different doses: low, medium, and high. For low dosing of Seroquel, this I'll use like 25 to 100. And so this low dosing is very helpful because this is what's used for insomnia. Now, I won't use Seroquel for low dose for just pure insomnia because of the weight gain side effects are associated with it. I know that I want some mood stability benefits, if I want some augmentation, like not just for sleep, but I know that I'm treating other stuff, then I think the trade-off is worth it for Seroquel. Then you get to medium doses around 100 to 400 milligrams. This is more the mood stabilizing dose. So this I'll use for depression, BPD, PTSD. So when I use it this way, this dose is using more of the 5-HT1 receptors. So this is using the histaminergic receptors. This is using the more of the mood stabilizing receptors. And then when we get the serotonin, then when we get to high, that's when we're doing the D2 block. And so this is for psychosis or schizophrenia. And so this I'll use for the high doses. And you can go from low to high with Seroquel. And when you can have that gradient, you can treat different things. And that's why I really like this medication, because then I can slowly titrate up based on what I'm trying to treat. For example, if I have a patient who has bipolar and they might have psychotic features, I could put them at, let's say, 300 milligrams of Seroquel. If that's enough, great. But because they have the psychotic features, it might need more. That way I can slowly transition upward as well. The outpatient dosing, you would go slower, but inpatient, you can go pretty quick. You can start at 200, 400, 600. Seroquel comes in two forms, IR and XR. The IR form is given primarily at night. This is my favorite form to give. So it's given QHS because of the sleep issue. So that's why, I want the sleep benefit, so I'll give it at night. Sometimes I can split it, but because its half-life is not that long, it's like 8-ish hours. So sometimes I can split it, but with biggest at night. So for example, I might do Seroquel 300 at bedtime and maybe 50 once or twice a day to keep some of that mood stabilizing benefits. I find that the IR does tend to last longer than even what half-life conveys. So even just dosing IR once at night, I have found be helpful for the vast majority of patients that I work with. So I do tend to lean towards the IR. The XR, you can give it at night, of course, or day. It's still sedating, but just not as sedating. So the XR can be given once a day. You could do twice if you wanted to, but it's not as sedating, but then the mood benefit is longer. A primary reason I like to use Seroquel is for the sedation benefit. So that's why I tend to lean more towards the IR, but XR is a perfectly acceptable option. For insurance might prioritize you to use IR, even though both are generic. So that's why I tend to prefer the IR version. For example, so I had this BPD patient, and so I had her on, I think, like 200 milligrams of Seroquel at night and 50 twice a day, morning and afternoon. The 200 was doing most of the sedation. The 50s during the day were not as sedating. And she wasn't getting too tired by them. So that's why she was getting the total dose of 300 at night. Another thing is that the XR generally has to be taken with some food for better absorption, which is another reason that I like the IR as well. So the metabolism of it is broken down by the liver, liver metabolism, liver met. So all this means, the liver metabolism, is that just be cautious in anyone who has any liver abnormalities. If their LFTs are very high, like in the 300s, 400s plus, anyone who's alcoholic, just be cautious with that. But it's not the end of the world by any means. Yeah, I know we talked about side effects throughout, but let's go through them all here. So sedation, which we take advantage of. Weight gain. So this is the biggest one with Seroquel. So I think of Seroquel with the 0. Seroquel, very notorious for weight gain. Diabetes, it can increase the A1C, lipids. All of that is a downside of using Seroquel. So that's the biggest negative. But the positives that we get from this is, because it's not very dopaminergic binding, then it tends to have lower EPS. So EPS is extrapyramidal symptoms. So it has lower this risk. So that's really good. If I have a really muscular guy or someone who's had EPS symptoms before, they might be more susceptible, and I don't need as hard hitting of an antipsychotic, then that's really, if you give a patient Haldol, they're probably going to get EPS, but with Seroquel, you don't need to do that. So you don't need to use cogentin or anything as augmentation, which is super nice. Decreased blood pressure because of the alpha adrenergic antagonism there. Some risk of QT prolongation, but it's on the lesser end. It's not like super contraindicated in anyone who's a cardiac patient, but just something to be aware of. But the biggest side effect by far, sedation, weight gain, the diabetes, A1C, lipids, and decreased blood pressure, but the benefit you get is the decreased EPS. So that's why you got to monitor this, right? You have to do the yearly checks, at least yearly. You want to make sure that you're monitoring this as well. Another thing with the EPS is that for the AIMS, you don't really need to do that as much. I mean, you should still do it, but like you're going to get much less risk of TD and the EPS. So overall, main things to know about Seroquel. So D2 antagonism, less potent. The sedation is the biggest thing. A lot of the mood benefits you get from that. That's my favorite way to use it, to use Seroquel. A lot of different uses depending on how you titrate. So that's the nice thing as well. But don't really consider it for sleep. You can use it for sleep, but don't just only use it for sleep unless you're also treating other stuff too, because there is other things that can be helpful. For example, like I had this one patient, I remember like he had some trauma issues. He was a 21-year-old kid. He was on a Cymbalta dose, 60 milligrams. As I diagnosed him, I knew he had some trauma component as well. So I started him on Seroquel, 100 milligrams, and now he sleeps really well. And he's like, wow, this is a lot of his mood lability just went away with the addition of that low dose Seroquel. So it's really good for augmentation. So yeah, hope that's helpful. And so if you're a PMHNP and you really want to learn more about psychiatric medications, diagnoses, you want to treat patients better, you want to be able to treat them with confidence, you want patients to really like you, respect you for your clinical skill, you want to be recognized at work, recognized by your colleagues, and get promotions easier because you're recognized for your clinical ability by your supervisors. Definitely look at joining our PMHNP community, because that's where I help PMHNPs a lot more in depth and answering weekly Q&As and stuff too. Yeah, I'll see you in the next video.